Moving on for the first panel of the event, the topic will be role of technology, innovation in providing quality healthcare and ensuring patient safety. The first panelist, I would like to invite Ms. Suparna Sengupta, CEO, Narayan Memorial Hospital. Suparna Sengupta, CEO, having over 25 plus of experience in healthcare, worked in great diversity state, starting from 200-bedded single specialty hospital to 1,200-bedded medical college hospital. Demonstrated ability in leading, motivating, and developing a professional team, organizational, networking, and coordinating with excellent interpersonal skills, transforming startup ventures into leadership position, turnaround of EBITDA, negative units to positive, identification, negotiating, and closing deals, forging new alliances, partnership. A MBA in hospital management with a medical law degree from National Law University of Bangalore. Her main objective is to work on the grassroots level, dealing mainly with preventive healthcare. Ladies and gentlemen, this is Ms. Suparna Sengupta. Can we have a huge round of applause, please? Next panelist, I would like to invite Dr. Ashish Sabharwal, Executive Director, Bakson Multispecialty Hospital. Dr. Ashish Sabharwal. Dr. Ashish Sabharwal is formerly Vice President and Regional Director, South Asia for Smile Train, the world's largest cleft lip and palate charity, specializes in people. Dr. Ashish Sabharwal. Next panelist is Ms. Manju Goyal, National Marketing Head, PMLS and SUV from Mindray Technologies. Her expertise in wide range of medical devices, sales and marketing technology, development and market research. Ladies and gentlemen, Ms. Manju Goyal. Our next panel is Mr. Gurpreet Singh Gill, Head Project Service, Paras Hospital. His expertise in MEP of hospital project and also Certified Energy Master Manager have executed many innovative ideas to bring down the power and fuel cost of hospital. Ladies and gentlemen, Mr. Pars. And last, the man who will lead from the front, who will hold the moderator situation, Dr. Shuchin Bajaj. Dr. Shuchin Bajaj, founder, director, Ujala Cygnus Hospital. He is a doctor, social entrepreneur. He was inspired by his root as the son of refugee parent to give up his work in Delhi, Delhi's biggest private hospital, and open hospitals, clinic, and digital health service aimed at providing high quality, low cost healthcare to communities that don't have access. He currently operates 18 hospitals in 5 states of North India, supported by a network of outreach clinic and digital health service providing free consultation to ensure everyone in the world has access to high quality healthcare services regarding to their financial, geographical and social status. Thank you very much panelists, and thank you very much for joining us. And now over to you, sir. Thank you.
Thank you very much. Thank you very much, Farooq, for a wonderful event, and thank you for inviting us all here. I remember I met Farooq many years ago for the first time in Mumbai at a similar event. And he was a very young trainee at an organization at that time, and I had told him that you'll achieve great heights one day, I'm sure. And it's amazing to see him organizing his own event. Many congratulations to you. Really glad to be here. And we are very lucky that we have such an illustrious panel with us. We've heard Abhishek speak very clearly in the morning how the healthcare industry as a whole is centered around this conversation of scarcity. Everything is scarce. Doctors are scarce, beds are scarce, hospitals are scarce. Everything is scarce, right? The whole narrative is built around that. And Bhattacharya sir pointed us out very clearly on what the future looks like, what will happen in robotics, ranging from pill discovery to patient care. And I think we are very lucky that we have this amazing panel that can actually translate the two conversations that were started into experiences from the ground, because we have people who've been working with patients on the grassroots for many, many years. I've also been lucky to have been working with a lot of patients all through my life, ranging from my medical education to now working in the rural and semi-urban communities. Also, I was very lucky that when the pandemic started, I became one of the start-up members, you can say, of a small WhatsApp group called Founders versus COVID. I was the only doctor founder on that group, rest all were techies. And we understood that something big was coming and governments were ill-equipped to deal with this one-in-a-century event that was about to happen. And we felt technology was the only way that we could fight this pandemic that was coming in. The group, of course, started to grow very quickly, and we had to rename it Startups versus COVID because there were so many people other than founders on the group. And then finally, the name got stuck as Project Step 1. At its peak, Project Step 1 was working with 21 state governments, completely free of cost for the government as well as for the patient, and made a total of 9.6 million teleconsultations during the COVID times for those 21 states. It was an amazing platform. 10,000 doctors volunteered on that platform. More than 3,000 techies volunteered on that platform. And it was an experience that is quite unparalleled on how technology can really do good. And people are willing to come on platforms to do good if you provide them the structure. So let us start with Suparna ji on exactly what do you think technology can do? I've given you a small experience of what I saw over the last 2 years. But what do you think technology looks like coming up in the future? How do you see it? Especially the fact that you do notice a change from hospitals towards home. Most of the people prefer to be treated at home and talk to the doctors from home. So how do you see this future panning out, and what have been your experiences on this?
Thank you and good morning everyone. It's been a pleasure to be with Farooq for some 2-3 years now. So it's always a very august gathering and it's a learning all the time. So I'll just start with something which has been in my heart for last 2-3 days. I had been into another panel talking 2-3 days on a healthcare conclave and based on innovations only. So there, I was also a speaker in the panel, and somebody, I would not like to name him, but from one of a very esteemed guest pointed out to me one thing, that madam, आप जैसे बोल रहे हो healthcare ऐसा नहीं है. Healthcare is not simple, very complex. But I think after sir, with taking a cue from you, I know we are doing a very good job. In healthcare, we are progressing, but I think till today, I think healthcare is quite simple. It's only how much care can you give a patient and how quickly you fix up his or her problem and get him back to feet is all about healthcare. So innovation and technology would only ease out that. And I think it's not that complex, it's simple. So, see, home health care had not been our, cup of tea when, we started some 23, 24 years back. We had this concept of general physicians. When we were very young, we had our Dadu. We call in Bengali Dadu, like we call the grandfather Dadu. We had Dadu and Dida, We used to fall sick and they used to call for the home physician. So we were treated and we got well. And everybody was fine. We didn't have to spend much. They would come and they would know all our history. When I first had my diarrhea and what causes my allergies, he knows everything. So I think we are back to that again. And home care, health care has become quite a thing of talk Even, see, I'm heading a hospital, I've been heading hospitals for last, I think, 15, 16 years. And every time we have this request from one patient, relatives or other, that, ma'am, what can we do when we take him home? So it's like the transition has to be like absolutely seamless. So it's the concept of hospice is not that prevalent in India, but the way it is in abroad. It's a home between the home and the hospital. But we had still yet to come to that. But, we had made a vertical in our hospital. We are trying to get into it. In my previous medical college also, we started this. We had a separate vertical for home health. And it is absolutely monitored digitally. We could cater to the emergencies. We can have these vitals checked. And everything was time bound. And like Abhishek was mentioning, like the cost of nursing or the cost of a RMO stationed by the bedside is huge. So we can e-monitor rather from the hospital, and if necessary, our people are going home and, we are bringing back the patient to the hospital. I think it's very important because the patient, there's a kind of loyalty which builds with the patient and the hospital. So for every other small things, he calls us, even, like he needs a small X-ray or he needs the tooth extracted for his grandson. So, small things also. So there's a kind of a bridge between that family and the hospital. So now the technology, how it is helping, we have a registration counter, and from there you become a member with the hospital. So there is 2-3 groups operating in Kolkata, like Potia or Tribeca is in a different segment, but here they are known as support elders or elder care. So we are with them. So there happens that they have a person who visits. We have an organization called 60 plus. They are only dealing with 60 plus people. So they have segregated themselves, like somebody is working in the geriatric phase and somebody is working for operative cases who goes home and can be rehabilitated. So this is, I think, the future. And I think technology is enabling it, and let's take it forward from here.
Thank you very much, ma'am. Yeah, I totally agree with you. I think the future is closer than what we think. In the next 4 or 5 years, I don't see anybody visiting a hospital for anything except life-threatening events or surgeries like organ transplant, etc. I don't see anyone else going to the hospital for anything at all. That doesn't bode too well for us, both of us, Ashish ji, you and me. So, but you've just set up a new hospital completely and you are heading it. And we all know that we are now entering the 4th digital revolution. We've always been digitally very active in the healthcare space at least, right? We started off with X-rays and ultrasounds, graduated on to CT MRIs and then computers for doctors, and then most of the hospitals work on the 3rd phase with EMRs and HIS. But now, of course, the 4th phase is coming with 3D printing, personalized medicine, medical big data, machine learning. So how are you incorporating all of this into your new hospital to ensure that patient safety is paramount? Because as we all know, medical errors are the 3rd leading cause of deaths in the world. So how do you take all of this together, seemingly big words, and make sure that, as Suparna ma'am said, make it as simple as possible and make it about patient safety?
Absolutely. I think learning from Suparna, we have to keep it simple. There are no two ways about it. There is no need to, get overwhelmed by all those big words that you just mentioned. I think what Suparna just said, that they used to have a GP coming in the hospital and he would know everything about the patient history, etc. So with the electronic health records being there, I think that's a great substitute where we will have all the information about all patients to be shared with any specialist. So I think information technology is the biggest game changer rather than the others. I mean, Everything else, the robotics and 3D printing, etc., they all have roles, undoubtedly. But to keep it simple and most accessible, which will affect or impact our lives, is information technology, where as simple things like writing a prescription, where you can get alerts, which immediately tells you that this medicine should not be there. Again, taking a clue from what you just said, medical errors. So if there are drug interactions, those pop-ups can come in prescription writers. All of this is available. See, the idea is to incorporate all of them. And to answer your question, how we have done this in our hospital, so we just got into a smart hospital management system which had all of this. Trying to be paperless, so the prescription straight away goes to the pharmacy where the medicines are dispensed. That's one. The other alerts that can come are, you see, if there are any lab reports which are off by a big margin, so those alerts are sent, or if some prescriptions or even the vital monitoring, etc., if that is also incorporated into that, that alerts can be sent to the people managing the whole thing. So, in a nutshell, I would say information technology is the easiest that is the answer for all of us as far as patient safety is concerned. That's a huge, huge role to play.
Yes, thank you very much, sir. And I'm really glad you broke off at information technology, because Manjuji is here, and I don't think we have a better expert to talk about information technology in healthcare, because she's been leading the Mindray initiative for a very long time now. So Manjuji, what do you think about what sir has said, and how do you incorporate all of that into patient outcomes and patient safety?
Yeah, sure. Thank you so much, Dr. Bajaj, for this question. Actually, this is quite close to my heart. And good morning to all ladies and gentlemen. I did not get that opportunity, so I'm doing it now. And regarding IT, actually, I take two words from what he asked me. One is the patient safety. That is, I think, close to all the people who are there in this room. Then second thing is quality in healthcare. Two different things, but all get related with one word, that is IT. And IT, for what I'm talking about, is about patient data. I'm not talking about the EMR, I'm not talking about HIS, because that is majorly maybe related to hospital administration. So I'm talking here about the patient data. Like when I say about the patient safety, one just small example, maybe many of us may have experienced it. Like in a midnight, we all know in India, one thing still is common is we have lack of expertise clinicians. And at the night, at the odd hours, we definitely, there is a scarcity for it. So in a midnight, the residents call a senior doctor. Sir, there is a problem, the patient BP is falling, SpO2, this, that. Then doctor, what he asked him, okay, tell me what's the heart rate, what is the SpO2, what is this, and what's the ventilator setting, what's the pump setting. Then he, as per his experience, he tells the remedy, and what he says, okay, please handle till the time I come. So he is giving advice as per the current situation he understood, and he's on the way. Now, in this situation, who is under pressure? The resident is under pressure. The doctor, senior doctor, he is under pressure because he has the information what he received. That may not be complete, that may not be that accurate. Then, now, whose safety is compromised in this scenario is the patient. So, okay, let's take another example now. The same situation happens maybe some other place. There, the senior resident calls, sir, there is a problem with bed number so-and-so. What the doctor does, opens his phone, sees the data, sees the vital, sees the ventilator, pump, monitor setting, and advise him, take this, and then please let me know if still there is a problem, then I'll come. Who is at comfort? That senior resident is at comfort. The expert clinician, he is at comfort, and whose safety is guaranteed now? The patient. this change patient data IT can bring to the healthcare. Then another point he said was very right, was the quality in healthcare. I'm from a small place. So, okay, God forbidden, if there is anything, my family also want me, get us admitted in a metro city, somewhere in Delhi, Gurgaon. They don't want to get treated in the tier 2 or tier 3 cities. Because why? Everyone who can afford, they want to come to metro city because they think the quality healthcare is better in those cities. They can't get it there. Why? Maybe one of the reasons can be they think the expertise at that place is not that great. We can, to some extent, we can help the situation here. How we can? If the data for the patient who is there in that remote hospital, if we set a command center at place where the expert clinician can see, can monitor, can advise, we can improve that situation of that remote hospital pretty much. And all of you know better than me why many good hospitals, they do very good in Delhi NCR, they don't do that great in those tier 2, tier 3. You know the reason. So maybe the IT can bring that bridge between those tier 2, tier 3 and the metro city clinicians, because virtually we are connecting. And when we talk so much, maybe one point we miss is the affordability. Because we believe no solution is a solution till the time it's affordable. We talk so much, but if it's not affordable, I'll not buy. So, and India is an IT hub. So the solution which comes to your doorstep has to be affordable. So if that affordability and the practicality helps, your patient safety and quality in healthcare is going to go better with IT. That's what we think of.
Thank you very much, Manjuji. Yes, of course. And of course, it helps that you have actually now more computing power in your palm than that was available for the entire moon mission when it went up in 1969. The entire rocket and every machinery and the entire NASA had lesser computing power than what you have right now in your phone. And that helps, of course. And I'm really glad you brought out the tier 2 and tier 3 problem, because that is something that we've been working on, and that is something that Gurpreet ji has been working on a lot, because Paras is focusing a lot on tier 2, tier 3. And we are seeing an evolution of healthcare that I think is quite unstoppable now. And we've seen it happening. That is why I am confident that it will go into tier 2, tier 3 as well. Because I don't know how many of you would remember the Delhi of the 80s. So if you had a heart attack in Delhi in 1980, you had no option but to either fly to Chennai or to the US if you wanted an angioplasty. Otherwise, you stayed at home or went to a government hospital, and maybe they would thrombolize you, maybe they would not. But for an angioplasty, you had to fly out, right? And this is exactly what is happening in tier 2, tier 3 now. They fly out to Delhi. But now look at what Delhi is, right? People are flying from all over the world. And that is what we at Ujala, Cygnus and Gurpreet ji at Paras have been stressing a lot on, to get these facilities to tier 2, tier 3. So we have 18 of these hospitals with 18 cath labs, 18 neurosurgical setups in tier 2, tier 3. Because we do realize that golden hour is of importance. You can't take a heart attack patient and hire a jeep, because ambulances are not available easily, right? You don't want to hire a jeep with a heart attack patient and a prayer on your lips that, okay, maybe we'll reach Delhi in the next 5 hours. So, since you are working so much on tier 2, tier 3, how is information technology and the digital revolution helping you in building hospitals that are appropriate, but as Manjuji stressed, are affordable for the community as well?
Thank you, sir, for this question, and good morning to all of you. As everybody knows, Paras is focusing on tier 2 cities. Like we have made a hospital in Ranchi, we have one in Patna, one in Udaipur. Now we are coming up in Kanpur, Srinagar, and in next 2-3 years we plan one in Meerut also and Ludhiana also. So tier 2 cities have a different challenge, okay? So first of all thing is we have to make a hospital which is like you have a proper space utilization of it. All the information is, we have a common IT hub in Gurgaon. So all the information is scattered between all the hospitals, okay? If you want any issues, you can take the advice of the senior doctor sitting in Gurgaon or somebody sitting in Patna. And the biggest thing that we face over there is that doctors are a challenge in tier 2 cities, no doubt about this thing. Getting a renowned medical staff, doctors, getting paramedical staff is an issue in tier 2 cities. But still, like all this, to overcome these challenges, okay, and to build a facility and to provide affordable healthcare, that is the biggest offset of this. And again, then building hospitals, the area that we use, the number of beds that we are able to add in that same area, the number of services we are able to provide. Like all hospitals have, they have onco centers of their own, they have cath labs, they have OTs, so that we can, under one hub, we can have all the facilities.
Right, I totally agree with you. And the fact that Manjuji said that why are these hospitals, the bigger ones, not so successful in tier 2, tier 3 cities? I think there's more to it than medical excellence and information technology. There is, I mean, a DNA that's working there, right? It's not in the DNA of the bigger hospitals to build lean organizations. Their setup costs are so high that they can never justify return on capital. They will spend 1.5 to 2 crore rupees per bed to set up something, and that is not really the solution for these tier 2, tier 3 hospitals, of course. So we can talk ad infinitum about tier 2, tier 3. I've spent my entire life there struggling to set up these centers, but I don't really want to go there, of course. But talking more about preventive health, I think, is something that has been missed in this conversation a lot. And we tend to underestimate the true cost of the disease that happens when you come into hospital, right? I mean, we know that there are 70 million diabetics in India, and we know that 1/3 of them will end up into kidney failure. That is the statistic that is staring us in the face, and we choose to close our eyes. We are amputating 1 foot per minute for diabetes. So, what are the costs of this disease that we have to look at? Is it really that you end up into kidney failure, you come to our hospital, we do your dialysis, and we pat ourselves on our back that, oh, we saved you 5,000 rupees because you had an Ayushman card and we did it through that? Is it the real cost of the disease? We do not count the indirect cost of the disease at all, because now that patient is in kidney failure or he's lost his leg to an amputation, he can't go to work, he's lost his job. So his future earnings that are lost run into lakhs and lakhs of rupees, which nobody is counting. And the most scary part is the intangible cost of the disease, which nobody even knows. Because he's lost his job, now he pulls his children out of school and starts sending them to work. So entire future generations are destroyed because we could not prevent his kidney failure. The government says, okay, you have the kidney failure, come to us, we'll do a free dialysis for you. But who's preventing that kidney failure? Only 9% of the Indian healthcare budget is going towards primary and preventive care. 91% is actually sick care. And all we talk about is healthcare, but we are not spending anything on it. So Suparna ji, what's your take on this? How can technology help on this? You stress so much about home care and how you are taking care of patients at home. What are you doing for preventive care through technology?
Preventive care is, I think now for last, I think almost 5 years, lot of things are happening on this. See, in the business summit, Bengal Business Summit, which you all must be aware by this time, like after our Chief Minister Mamata Banerjee came for last 3 years, we had been only for the COVID, 2 years we did not have. So she has made there's a unique thing which will be, I think, is taking shape really very fast, that in BGBS we had been seeing it come into full action. It's like 88 centers has been formed in the first level in tier 2 cities, where it's named as Shasto Ingit. Shasto is health in Bengali. So it's Shasto Ingit. It's like a digital platform. Is operating in a hub and spoke model. Like you have all the primary health center, PHCs, then you have the block level, then you have the district for the secondary care. So what is happening from the government, all the primary health centers are now equipped with a monitor, a camera, a webcam, and there you have nurse practitioners. That's excellent, I also personally feel, though I'm not a doctor, there are doctors in this panel, you must be saying that the RMO, the interns which we have now in the hospital, I think some of them might be very good, but I think mostly the consultants, they rely on the sister in charges. If you want to read a ventilator, I think the sister is reading it well than a new RMO. I mean, they need a little more time. I think the training which we are giving to the doctors, or they have been pushed into internships and they are busy studying for the MD, such amount of pressure on them. And after 8 years of studying, they are trying to find a match, to look for a girl or look for a boy. Half of the life is gone struggling. So I think, we have to also look into that, because nurses has to be elevated. I mean, they have to be trained further. So these Shasto Ingit centers in the primary health level, they have an auxiliary nurse or a nurse practitioners. Or, because you see you must be agreeing with me, a lot of doctors, they don't want to do rural duties. They don't want to go. Now what happens? So we need to elevate them, train them, for at least for the basics. So you have this monitor, you have a patient, you check his vitals, and immediately, it is getting there and it is getting uploaded. And the devices are connected. The blood pressure device, the ECG, they are all connected. So the doctor who is sitting at the block level or on the district level can see the parameters immediately in front of him. Then the reports are also getting uploaded. So the block level doctor is there to advise. So what is happening? So I, as a hospital person, what we did is we tied up with this block level centers. So we are now taking consultants, like with the Rotary, with the Lions. We are doing this because they are into a lot of philanthropic activities. So we are going down to the primary health center for health screening. So it's if I have to take a very busy cardiologist to a rural center, he would say, Suparna, you're wasting my time. Do you think I have time to screen around 100 patients? Kiska kya hai? So what we are doing, we are getting them screened. ECG ho ja raha hai, blood pressure, dietary habits, history, all is with us. Now I select, ठीक है, इसमें से like around from 500 people I've screened over last 2 weeks, 50 looks potential for cardiac ailments. So then I'm taking my consultant there, and then he is screening. So I think this is helping, and government is very, very keen on this. So when I went to the health secretary, I was asking him that can we take it up in a PPP model. So he's not very interested. He's telling for a private person to work at this scale is important, Suparna. It's just doesn't happen that way. But maybe, in the future, this will have this PPP, coming in here, because we need doctors, lot of doctors to go. And we don't need people to travel, just to see a doctor. They have to come all the way. They have to come with their family members. There's a cost, no matter where to stay. So even the district hospitals are now getting equipped with cath labs. So government of West Bengal, they're coming up with around 51 cath centers in the block level. So I think these are the things which is happening. Let's see.
Yes, amazing. And I totally agree with you. We need to shift from this doctor-centric model, because it is impossible for us to get doctors to these primary health centers. More than 25% of PHCs in India do not even have electricity or water connections. So how can we expect doctors to sit there? That is the problem in the entire model, and we must look towards NHS for learning how they've consciously promoted GPs and nurse practitioners for primary and preventive health. So as late as the 1980s, their admission rate for COPD patients was almost once a year. Every patient would go once a year to get admitted because of the exacerbations. And they've brought it down to less than 10% now, just because GPs and nurse practitioners have been empowered so much for preventive and primary health care. And
Even, sorry to interrupt, the Ayush doctors can also be a part of it? They can be, you know? Okay.
absolutely, absolutely. But we'll have to talk to IMA. Ashish sir is a very big member there. There'll be big blowback for all of us. But Ashish sir, we all appreciate how tough it is to get doctors, right, to work with us. And I think it's great that Job EZO, a platform like that, is sponsoring this main event, because using of technology, I think, is imperative now. How are you using technology to hire the best doctors that you can find?
See, we are in a tier 2 city, Greater Noida, so doesn't seem too difficult. As I said, I would always say, keep things simple. So there's no need to look for technology when you are there, when the doctor in Greater Noida is available. But to answer your question on preventive health and stuff like that, see, all the data that is coming in, that is going to be a huge thing even for the insurance companies. All our healthcare today, with the penetration of insurance going so deep, so you can imagine that almost 75–80% of all hospital admissions, in at least in the bigger cities, are all through TPAs and panels, etc. The cash patient is low, except in the tier 3 cities and tier 2, where the panels and the insurance is not there. But with all this data being analyzed and everything, we can certainly come forward and find out what are the preventive measures that need to be taken for which diseases. Even for every hospital can realize, once you have enough critical mass of data, you can find out that what are the things that you are looking at, what are the patients that are coming in and seeking health care. So preventive could be in two ways. One is creating awareness, and the other is actually looking at what is going to happen and then go in for prevention. So one is the simpler way of saying that, okay, cervical cancer, big thing, we need to create awareness, get the women in and get them vaccinated or whatever, or change their habits or whatever. But the other is, analyze all data and then find out that this is likely to happen with all of this coming in. So that, I think, is going to be a game changer again.
Absolutely. Thank you so much for that wonderful pointer. I'll definitely note it down and use it in the future. But coming to that, Manjuji, how do you think is IT? So you spoke about issue situation where patient safety is at stake, and a very valid situation, of course. But how do you think IT can play a role in this prevention and making sure that the patient doesn't reach the ICU?
I was thinking in my mind, I missed this point, but I don't know how you just asked me, so I'm getting an opportunity again to answer it. Because, I just took an example of ICU. So, but he said how to prevent going to ICU. Because like if the patient is in a ward, normally the patient is with we say vital signs monitor or multi-paras, basic monitor. So that basic monitor does a basic job. Then there is a nurse who will have a chart like this. She will be noting down certain points, and that is how the process goes in most of the hospitals. Now, during this standard procedure, what can happen sometimes, like the patient is prone to infection. Sometimes it can be, okay, I'm not a doctor, but okay, certain situation I'm just bringing in front of you. How that can your technology can help you to predict this? There is a chance? Yes, your device can help you. Sometimes the situation of, we say the coma, there is a technology to help to predict you, there is a chance. So if your technology is telling you this reduces a lot of workload, and this reduces the chances of going to the ICUs or intensive care, because you have caught that possibility at pretty early stage. So this helps the clinicians, this helps the nurses, and this in fact reduces the manual error chances. We all are humans, like nurses, like Madam also raised that point pretty well. Our system is dependent too much on nurses. They have to handle maybe 10 equipments per patient. They have to handle a lot of paperwork. So during that process, they, like during the shifting, they may miss out some data, but that data can be vital. So there the technology helps us to give a better patient health care. And
Dr.
again,
Sorry. Dr. Bajaj, see, if in a similar situation, if you know that there is an endemic or whatever, something that is going along, and then you find out from the nearby labs, that is what a smart physician like you would be doing, calling up your friends in the lab, yaar, aajkal kaun sa chal raha hai, and which antibiotic would be better if you look at the culture sensitivities, etc. So a similar thing, if this can be done on a larger scale and then we find out, and then you would come up with better and share that information with the healthcare providers. So you would be using the right antibiotics and cutting down the time to get to the right base where you want to.
Yeah, absolutely, and I think we are doing it on a much larger scale now. So we all heard about the London incident, and I have a very dear friend, Noor, who works specially on this field, that they track viruses and other organisms in the sewage. They keep analyzing the sewage and see which viruses are increasing. So they detected the polio virus in London in a sewage plant. And now they have a full-blown national scare that polio is coming, and they are tracking that patient who flew in. So we are, I think, quite ahead on that for the preventive part. So as somebody said, outbreaks are unavoidable, but pandemics are not. So you can actually avoid them if you track them down in time. But Gurpreet, aap bataiye, how do you ensure that preventive healthcare is taken care of in your hospitals and outreach settings? Because we work in Tier 2, Tier 3 a lot, and we do a lot of sehat chopals, going out to the villages, screening them. We reach out to almost 100,000 patients every month in the villages themselves, so that we can reduce their costs of the disease. But are you using any specific technology in your hospitals to do that?
Yes, see, I will just share my experience, okay? Prior to working with hospitals, I was working with pharma company. So over there, cross-contamination was a very big issue. Like if one product is being manufactured, you can't start the other when it has been fully sterilized and all these things. So like while building a hospital, I basically belongs to the project team. So we take care that a proper patient safety is taken care. There is no cross-contaminations. The ICUs and the CCUs are proper. There's a proper separation between the air quality and everything. So there's a proper segregation between the OTs, the isolation rooms, everything is taken care, because once a patient is entering the hospital, he's already suffering from one of the disease. It shouldn't happen that after entering the hospital, he catches some other disease, or there's some cross-contamination in the body or in the air over there. So we take care of all these things while building a hospital, while running also, while operating also. And also nowadays we have started cohorting, that one floor is for ortho, other is for neuro, the third is for onco, so that all these patients are kept far away from each other.
Yeah, hospital-acquired infections. But I would like to ask you a question. You've been doing, you just mentioned reaching out to the villages, etc. Do you think the villagers are ready to do a virtual teleconsult in terms of preventive health or screening? I'm not talking about proper treatment. So,
so like all lazy people do, we had also convinced ourselves that our villages are not ready to do this, because we were not equipped to do this. So, as you know, the famous saying is that entrepreneurs are people who jump off the cliff first and then build an aeroplane on the way down. We were actually pushed off the cliff when the pandemic came, and we were like, there was no OPD, no touch with the community at all. And we started our telemedicine services in 3 days flat. And at the peak, we were doing about 40,000 teleconsults a month in the villages. Even now, we are doing about 15,000 a month. That behavior has stuck. It has not gone away completely. So villages are ready, of course. There is no problem there. If you give them technology that is for their benefit, they will definitely take it. I think we can keep speaking for a long time, but we've run out of time, unfortunately. Thank you so much for joining. And if there are any questions in the audience, we can take one or two, but we don't really have time. If there is any question, we can take maximum one or two. I don't think we have. So thank you very much. Thank you all the esteemed panelists, and thank you once again, Farooq, for having us here. Thank you.